It'll be great. Hello, everyone, and welcome to today's webinar, Learning to Interact with Challenging Patients and Their Families. My name is Amanda, and I'm the Marketing Manager here at AOTA, and I'm going to point out a few things about today's presentation. First, CE. You can earn 1 CE contact hour for each webinar attended during Member Appreciation Week. At the conclusion of the webinar, you will receive an email from AOTA Webcast containing a link to your CE certificate. However, you must stay on for the entire webinar until you view the pop-up screen that says the webinar is now over in order to receive your CE certificate email. You will have through December 31st to obtain your CE certificate. Next, questions. On the left side of your screen, you'll see an Ask a Question box. This is for you to type in questions you may have for our presenters throughout the webinar. Questions will be answered towards the end of the webinar, and the presenters will do their best to answer as many questions as time allows. And last, resources. The PowerPoint presentation for this webinar is available for download and can be found in the Event Resources box located just below the Ask a Question box. Simply click on the pull-down arrow to view the document and download. And with all of that information, let me introduce today's presenters, Christina Azar and Lynette DeFrancia. Ladies?
Hello, everyone, and thank you for joining our webinar, Learning to Interact with Challenging Patients and Families. My name is Christina, and I have Lynette here with me today. Before we begin, we'd like to thank AOTA and Amanda for this opportunity, as we truly feel that this is something that is not spoken about enough, and it's useful for all practitioners, new and seasoned. We have 3 different learning objectives for you all today. The first one is being able to recognize different types of challenging situations and their characteristics. Second one is being able to manage and diffuse challenging patient and family encounters using the techniques and strategies provided. And lastly, to become more mindful of the ethical and educational considerations when working with challenging patients and families. Before we go further into our presentation, we'd like to take a moment and tell you all a little bit about ourselves.
Hello, everyone. My name is Lynette DeFrancia, and I'm an inpatient acute care occupational therapist at Ronald Reagan UCLA Medical Center, which also happens to be a level 1 trauma and teaching hospital. I've been in OT for 17 years, and my area of practice has primarily focused on cardiothoracic intensive care, heart and lung transplantation, mechanical circulatory support devices, and ECMO devices. In addition, I also precept level 1 and 2 fieldwork students, as well as new and junior staff members.
And my name is Christina Azar, and I'm also an acute care occupational therapist at Ronald Reagan UCLA Medical Center. I started off at UCLA as a level 2 fieldwork student, and Lynette was actually my CI. I transitioned into a full-time employee just this past June and have fallen more and more in love with acute care. I primarily work in the cardiothoracic ICU and step-down units, but I also spend time with the breast reconstruction and ortho patients. I wanted to take a moment and have everyone reflect on their experience as an OT, a CODA, or OT or CODA student. Have you ever had to interact with a difficult patient or a family member of a patient? I want you all to know that you are not alone. This is very common. I'd like to read you all a quote from Klein and Liu, and the quote says, "Families are almost totally unpredictable. In families, they can be horrible to work with, just absolutely horrible. I mean, they walk on the unit and you want to run. You know that you have to go talk to them, and they can be incredibly judgmental and incredibly abrasive, and actually to the point where they're abusive to you." This came from a qualitative study that interviewed 16 occupational therapists from various settings, and it just shows that regardless of what setting we're in and who our patients are, working with somebody who is difficult is inevitable. And we hope that by the end of this webinar, you all have some new tools and strategies that you can use in your own practice.
I think a lot of us can relate to the quote that Christina just read, because having a difficult or challenging patient is not an isolated experience. In fact, in a 2006 study that looked at how respected family physicians manage difficult patient encounters, the authors state that having difficult patients appears to be an almost universal experience. And just so you know, most of the literature on this topic refers to patients as difficult. So we may interchangeably refer to patients as difficult or challenging during our presentation. And as we jump into our topic, I think it's also important to know how the idea of a difficult or challenging patient came about. So in the literature that Christina and I found on this particular topic, a big portion of the research had been conducted by physicians, so it's no surprise that the term difficult patient was first described by physicians. As a matter of fact, a physiatrist named Groves was actually the first to describe the concept of a difficult patient and categorize them into 4 types: dependent clingers, entitled demanders, manipulative help rejectors, and self-destructive deniers. And so, flash forward to 2019, where the authors, Sarah et al., conclude in their study that our general idea of what a patient should be and act like stems from a paternalistic approach to medicine. And this approach is where the patient relies on the healthcare professional for medical information and does not question him or her. So when Christina and I were researching for our topic, we came across the term heart sink patient numerous times in the literature. And this term came about from a general practitioner who described these heart sink patients as those who triggered a mixture of emotions, such as exasperation, defeat, and sometimes plain dislike, causing one's heart to sink. So after reading this description, I'm sure some of you out there already have a patient like this who comes to mind. I think this is a very relatable term and feeling because every practitioner has felt this way at least once in their career. A physician named Ed Goose suggested that heart sink might be the better term rather than difficult or challenging because the problem may not be with the patient, but rather how we feel about the patient. And I think it's also important to note that just because a patient might be difficult for you, it might not be a difficult patient for another therapist. So I'd like to share a quote by the author Feister, who states that hostility, anger, depression, anxiety, and even noncompliance are common reactions to difficult circumstances, even among the psychologically healthy and typically well-adjusted. So I think it's helpful to keep in mind that a difficult patient may not always have a mental disorder that we stereotypically tend to think of with these patients. In fact, they can be also normal, everyday people who may now have to face some bad news or difficult circumstances. I think another important point to remember is that any patient can be perceived as difficult, and any person has the potential to become a difficult patient. So now, Christina and I would like to discuss the 3 main factors that can contribute to challenging situations, with the first one being patient factors. In 2017, a study by Sanditsky et al. Said difficult patients comprise 15% of physician examinations. And during our literature review, there were certain patient traits associated with difficult patients. They were mental health disorders, specifically depressive and anxiety disorders, multiple symptoms, meaning more than 5, chronic pain, poor functional status, unmet expectations in the sense of the medical team not being able to have a clear diagnosis for the patient, reduced satisfaction, and frequent use of health care services. And in our research, we also found that patients who were uncooperative, non-compliant, demanding, manipulative, had some substance abuse issues, were violent, aggressive, and also had negative healthcare experiences were also viewed as challenging. So now, Christina will be discussing the second factor.
The second factor that can contribute to challenging situations is actually us as practitioners or clinicians. So we can contribute to challenging situations because of a lack of empathy, an inability to properly explain medical diagnoses or plan of care, poor communication skills, our own personal biases or stigmas, how we personally view the patient, their inability to listen to patients, or if we don't include them in decision making, a lack of job satisfaction, and poor nonverbal communication skills. The clinician's personality, work style, belief system, cultural gaps can also impact the way we interact with patients, which can ultimately make a situation challenging. The way we as practitioners view the patient can also impact our plan of care, because once we label a patient as difficult we may not treat them as we would other patients, whether we realize it or not. In return, these difficult patient encounters create negative attitudes that can lead to therapist burnout, increased workload, work-related stress, and decreased job satisfaction. Lastly, the amount of years of experience a clinician has can also impact patient-clinician encounters. There is a statistically significant correlation between years of experience and number of challenging patient interactions. This means that the more experience a clinician has, the less challenging interactions they experience. Lastly, the third contributing factor is situational or system factors. These include flaws in medical care or insurances, long wait times, a lack of resources, and interactions with the patient's family members. You and your patient may get along just fine, but if their family is abusive or overbearing, it can cause hindrances to therapy. Challenges in the system can also include the role of the patient. We, as occupational therapists, have to look at the patient as a whole. We have to think about what their responsibilities are. Are they a caregiver to a child or elderly parent? How does their new diagnosis affect these responsibilities? Does the patient have a poor support system? Socioeconomic status can also be a contributing factor. According to Millikan, chronic socioeconomic deprivation over time can lead to a lack of perceived personal agency, leading a person to fail to act on his or her own behalf because they see themselves as powerless. This can cause patients to lose the ability to advocate for themselves and ultimately get lost in the system. In cases where patients are difficult and have complicated medical issues, we may just not have enough time to see them. They probably have other demands like x-rays, MRIs, other therapies, other consults that are trying to get to these patients, and we have a whole caseload in addition to these difficult patients. So we simply may run out of time. We created this next slide to show you all that it's not just one factor that contributes to these challenging situations, but rather an integration between two or even all three of these factors. So now that we know what factors can contribute to difficult situations, it's important to learn how to go about or diffuse these situations.
During our literature review, Elder et al.'s 2006 article found that there was a lack of best practice for practitioners dealing with difficult patients. And a lot of the literature out there on this topic consisted of editorials about strategies, patient-physician communication, and how best to teach how to care for these patients. So for this webinar, Christina and I reviewed the literature and compiled a list of frequently cited strategies and techniques when dealing with challenging patients and families. And we've arranged them in terms of increasing difficulty. So the first set of techniques on this slide are probably the easiest to carry out by the practitioner, and I'd like to think of them in terms of what you can do to prevent a challenging situation. So this brings us to our first strategy and technique, prevent by recognizing and anticipating a difficult patient and family situation. So a lot of times, you'll get this information in the forms of a heads up from a coworker, staff member, or maybe during interdisciplinary rounds. So it's helpful to create a plan or at least a script in your mind beforehand so you'll know what to say or how to act ahead of time if the situation were to happen. And if the situation were to arise when you're actually working with the patient or talking to the family member, it's also helpful to be aware of any change in tone, mood, body language, speed of speech, because it actually might indicate that the patient or family member may not be comfortable with the conversation or treatment. And so if this is the case, you might want to redirect the task or conversation and come back to it at another time if necessary. So this leads us into building rapport and establishing trust. Building rapport and finding common ground with your patient is helpful because it actually reduces any tension that might come about. I also feel that building rapport and earning one's trust is helpful overall just to prevent challenging and awkward scenarios. And so for establishing trust, this can be done by making sure you are taking care of the patient or family member's psychological safety. And so you definitely want to create a favorable interaction with the patient and family. so that they feel safe, and you want them to feel that they can openly communicate with you. And these can be little things such as coming back when you say you will, or calling the nurse to ask for pain medicine if the patient is in pain. And when I do this, I try to do this in front of the family so they really can see that I'm really making a concerted effort, that I'm trying to take care of their loved one. You also want the patient and the family to feel confident in you, and you want them to feel like they can trust you. And so a lot of times I feel like when I've gained the patient or the family's trust is when the family member who's been in the room or in supervising my treatment sessions since eval finally decides that they can actually step out and maybe take care of themselves. They can go downstairs and get a cup of coffee, or maybe get something to eat. And I feel like when that point is established, I really feel like I've somehow earned their trust. Because I feel like if a patient or family member does not trust you, it can be very difficult to move forward or progress in therapy.
The next factor or strategy we have is actively listening. This is essential to providing a high-quality level of care to our patients. If we can show that we are actively listening and engaging with our patients, then we can prevent challenging situations from arising. This means taking the time to listen to their concerns, thoughts, and questions, and even answering their questions. And in the case that we don't know the answer to their questions, it's important that we find out the answer and relay that information back to the patient and their family. We also need to be non-judgmental when we listen to our patients and refrain from letting our own personal biases interfere with what the patient is saying. We can show that we're actively listening by nodding, making eye contact, and sitting or kneeling so that we're facing our patient directly. Next, we have effectively communicate. This is key because how can we expect our patients to follow through with our therapy plans if they don't understand? If patients are unable to understand the therapy plan, it's our duty as occupational therapists to clearly communicate and repair broken communication, because poor communication is a barrier and it can affect the way we treat our patients. It's important to use a translator if our patient is not primarily English speaking, and to use colloquial language rather than medical jargon. We can also provide handouts and physically demonstrate what we want our patients to do so that we are sure that we are communicating clearly. We also want to be aware of our tone of voice. We want to be calm and respectful. That way they are really listening and understanding what we're saying. Next, we have body language. We want to be aware of our body language and how we present ourselves to our patients. Our patients and their family members can read our body language and our facial expressions, and we only get one first impression. So if we enter a patient's room with a frown, they may have already decided that they don't want to work with us. This means not crossing our arms, want to continuously look at the patient. And this also means not standing over our patients, kind of getting at their level.
And so these next set of strategies on this slide tend to require a little bit more action from the therapist compared to the previous slide. So at this point, there should be some sort of awareness from the practitioner that a challenging situation is about to surface if it hasn't come about already. And the first one on this slide is persuasion. So as therapists, I feel that we tend to use persuasion a lot. And in persuasion, the goal is to try to get the patient to be compliant. So how many times have we tried to convince our patients to work with us? How many times have we tried to get them to get out of bed with us? And persuasion can be done in different ways. But in the literature, it ranged from advice giving to the extreme of threatening, which I do not advise or condone. And so the next strategy would be collaborate and compromise. Compromise was a technique that practitioners used in the literature when they had somewhat given up on persuading their patients to be compliant, but didn't necessarily want to go as far as avoiding their patient. So it's helpful to find middle ground with your patient and their family. And obviously this is kind of coming about through a dialogue. And that's one of the best things about compromise is because it allows for that possibility. You haven't really closed the door in the sense where the patient doesn't want to talk to you. So that's probably one of the better strategies about compromise. When working with challenging patients and families, I think it's also helpful for us to be self-aware. I think it's helpful that we need to be aware of our own triggers, biases, and essentially our baggage. It's helpful to recognize the reasons for our own response patterns because it actually allows us to avoid being directed by our feelings. And this is important because as practitioners, we need to maintain a sense of objectivity.
Next, we have being empathetic and compassionate. Being empathetic and compassionate can turn a negative interaction with a patient or their family member into a positive, successful one. And that's why it's so important for us to be empathetic and compassionate. We can extend empathy by focusing on the patient's emotions and being compassionate. We can also try to put ourselves into our patient's shoes to better understand how they are feeling and sympathize with them. I think it's also important to be cautious of the family and know that they probably need our empathy and compassion as well. We have to remember we're treating essentially the whole family unit, and we want them to know that we actually do care and we are empathetic and compassionate to their situation. Next, we have an appropriate use of power. We often treat patients in their most vulnerable stages in their lives. We don't want to intimidate our patients, but rather promote equality between the patient and the clinician. Both the patient and the clinician should have power during the therapy session. The therapist is the one that offers treatment options and can control the flow of the session, but the patient has the power to either choose whether or not they want to participate or even adhere to the treatment plan. We want an appropriate use of power, which includes setting the rules of clinical management, boundaries, and limitations, but all in a respectful manner. I think it's helpful that if our patient is in bed or in a chair, we pull up a chair and sit next to them so that we're facing them directly rather than standing above them and talking down to them. I think it helps the patient feel like we're equals with them.
And so for this last slide, these strategies require a bit more insight, experience, and a level of comfort from the practitioner. During the rehab process, we need to consider the patient's family and collaborate with them because literature has shown that family involvement can contribute to successful rehabilitation. And so I think in addition to asking what the patient goals are, we should also be asking the family if they have any goals because, again, like Christina said, we are treating not just the patient, but rather also the whole family. We should also keep in mind that a family member may wish to be involved in goal setting or intervention at one point in time, but might be worn out, overwhelmed, and frustrated at another. So we need to be sensitive to the shifting needs, feelings, and levels of participation of family members. In terms of family collaboration, one of the barriers cited in the literature was scheduling difficulty. Things like family training tend to be difficult because it does take time, and also because of the multiple demands of our practice settings, it can be difficult to do all that on top of treating patients all at the same time. Another barrier to collaborating with a family was the difference in work schedules. So most therapists, they tend to work normal business hours during the weekdays as well as family members, and oftentimes for some family members, it can be difficult to take time off of work to try to schedule those training sessions. And so one of the things that they did is they kind of noted that because when it just makes it difficult for the interactions because when they're there in the evenings and on the weekends, some therapists are not. So it just definitely limits the interaction between both of us. In terms of consulting coworkers, I think consulting your coworkers is a great strategy to use if you don't do so already. And so hopefully there are therapists with varying levels of experience in your practice setting to draw information upon and share their experiences with you, because what might appear as a challenging situation to you may not be the case for another coworker. And a lot of times what I've done in my practice is also consult the PT that's also working on this difficult case with me. We try to have a game plan before we see the patient so that we're on the same page. And we just want to make sure that we're communicating effectively. We don't want to have one therapist say one thing and have the other therapist contraindicate that. So it's always helpful to consult with coworkers, even if it's from another discipline, just because it helps with cohesiveness. I think it also helps to debrief or discuss a challenging situation with a coworker after it happens, because it's likely that you aren't the only one to experience this type of situation. And in the literature, having a confidant or an informal support structure were some of the ways that the therapists cope with challenging patients and scenarios.
The next strategy is knowing when to draw the line. We need to recognize when the patient is asking for something that is unsafe or contraindicated and know how to say no in an effective and professional manner that promotes good patient care. At the end of the day, we are the professional therapists, and it's our licenses on the line. We need to use our best clinical judgment, and if we feel the patient wants to do something unsafe, we need to advise against it. We also need to know when to give the patient to another therapist. We need to be able to self-reflect and recognize when we are no longer the right therapist for the patient. We may have run out of ideas, we may not be getting along with the patient, or may just need help. If this is the case, we may need to pass the patient along to another therapist. It's important to do this not only for ourselves, but for the patient as well, because it may benefit them to see somebody new. If this is the plan of action we wish to pursue, then we need to find them another clinician rather than discharging the patient from therapy altogether. The last technique we have for you all are support groups. We should be able to recognize when our patients have psychological needs that we cannot manage on our own and be aware of the resources available to our patients. One of these resources can be support groups. As previously mentioned, psychological issues can be a big contributing factor to challenging patients, and helping our patients find a support group can minimize this challenge and overall help our patient. In addition to support groups for our patients, we need to reflect on our own feelings and our own psychological needs. If we feel ourselves getting upset during work or letting our emotions get the best of us, it's helpful to find a confidant or coworker or mentor that we can use as our own support group and confide in them and ask them for help if we need it.
And so while it's impossible to go over every challenging situation that may arise, it is helpful to be prepared beforehand. In OT school, they typically teach us how to interview and educate the compliant patient and the family member. But what about that challenging patient or family member? What about that family member who is fiercely advocating for their loved one? OT curriculum may touch upon these issues, but this is where fieldwork comes into play. And as a fieldwork clinical instructor and senior therapist, I feel that there should be a responsibility to show and guide students, as well as new practitioners, on how to navigate through these situations, because they tend to occur for the first time during clinical internship. And during our research on this topic, the literature discussed the idea of this hidden curriculum, where students and practitioners' actions were influenced by their mentors or instructors on how to deal with challenging interactions. So whether or not you're aware of it, the way you currently practice does have an effect on future practitioners. In 2019, a study by Steinauer et al. Looked at what medical students wanted to be taught for when caring for difficult patients. And I also feel like these findings could be applied to OT. And in this study, the student wanted certain things. They wanted social topics and interpersonal dynamics between the provider and the patient. And the example that they gave was discussing discharge plans with patients who did not want to leave the hospital. They wanted small groups to prepare and discuss for challenging situations while in the clinical setting, which is reflection. They wanted to hear from a staff member's own challenging experiences. They also wanted a debrief soon after a challenging interaction. They wanted feedback on what went well, as well as what could be improved. And lastly, they wanted to observe other staff members interact with difficult patients, and this is known as modeling. In a 2007 study by two physical therapists, Housley and Thompson, they found differences in the way that senior and junior PTs viewed difficult patients. And I thought this was really interesting because they found that the senior therapists were more confident in predicting their patients' outcomes. They were able to focus on verbal and nonverbal communication in the interaction. They knew their own knowledge limitations. They also had enough skills to change the route of the interaction or redirection. They were able to work collaboratively with their patients, and they were also able to draw from a wide variety of theoretical bases. And in terms of the junior therapists, inexperience, lack of time management skills, difficulty getting to know the patient's story, and the struggle to get the patient to comply rather than cooperate with him or her was actually a factor during these challenging interactions. The study also goes on to state how patient treatment observation of a challenging patient was helpful with the tacit knowledge and alternative ways of thinking during challenging situations for junior therapists. And this has to go with the modeling technique that I discussed earlier.
I also think that for me, being a new practitioner, the modeling technique that Lynette spoke about has been really helpful. It's been beneficial to see senior therapists work with not only challenging patients, but just any patient, so I can see how I should structure my own sessions and get ideas for my own evals and treatments. I found these last two articles we spoke about extremely relevant because as a new practitioner, that feedback is so helpful, and I really do feel like it can benefit myself and other new practitioners navigate through these challenging situations that can arise in our everyday practice.
While Christina and I were researching for this webinar, we had a really hard time finding OT-based articles on this topic. In fact, we only found one journal article from 1997 by Finley that discussed how OTs viewed their patients. And in this study, the study found that OTs were reluctant to admit not liking certain patients and stereotyping them, but they made social and moral evaluations. And so these evaluations seem to occur in the context of trying to obtain positive treatment outcomes rather than simply passing moral judgment. So the example that they gave was evaluating a family in terms of whether or not the family was able to afford a large piece of equipment that the patient needed if it wasn't covered. So even though we have the best of intentions, we as a therapist still need to be mindful of the labels that we give our patients because they can be stigmatizing, stereotyping, and disempowering, even though the consequence is not life and death in nature. And I think in cases of extremely challenging scenarios, one of the resources that we are fortunate to have here at our facility is an ethics service. And one of the roles of the ethics consultation service is to help resolve those ethically charged conflicts between the patient, family, and the clinical team, as well as to successfully manage them. The other role of the ethics service is to reframe the patient and family situation for the staff members involved in the patient's care so that the staff can understand the source of the patient's or the family's feelings and behaviors, all while promoting empathy and compassion. Another resource to refer to is the AOTA's Occupational Therapy Code of Ethics. As therapists and practitioners, the principles and standards of conduct listed in our guide our practice with the intent to provide the best care possible to our patients. And we also want to provide a safe discharge for them. When challenging situations for the therapist arise, and it tends to arise when the patient or family's ideal discharge situation differs from yours as well as for the rest of the team. When you start to get those questions in your head about what should you do in these situations, I think it's helpful to refer back to the related standards of conduct under each section to help guide your thinking and course of action for your patient.
So what's the relevance to OT practice? In a study by Finley, she wrote, it's called Good Patients and Bad Patients, How Occupational Therapists View Their Patients and Clients. And I know Lynette touched on this study a couple slides back. But we really liked this article because we felt like it accurately summarized what we as occupational therapists do. Without realizing it, we judge the social worth of people in order to balance the time and resources. Patients that are our favorites are those who are motivated, positive, warm, and responsive. These are the good patients. And they lead us to have increased job satisfaction. These are the patients that make us feel good, valued, and effective. We want to see these patients, and we go out of our way to work with them. Patients that are our least favorite are those who are uncooperative, unappreciative, boring, and unmotivated. These are the patients that make it more difficult for us to do our jobs and can ultimately lead us to less job satisfaction. Finley also described difficult patients as those who are emotionally and clinically challenging. These are the patients that are considered hard work, and we sometimes just don't know how to best handle them. This doesn't make them good or bad, it just makes them challenging. I think overall, regardless of whether our patients are good, bad, challenging, whether we like them or not, whether we agree with them or not, it's our duty and our obligation to provide the best clinical care we possibly can to them. I know we're a little ahead of schedule, but at this point, we would like to transition into the Q&A portion of our presentation. Okay.
So the first question we have is, hello, I am a year 2 OTD student. How do you know when to refer out this challenging patient if it becomes too much for you as a practitioner? So I think for me, I definitely think the first line of defense is just try to work through it. Obviously, we gave you some strategies to try to work with these challenging patients, but I think the first thing is to try to see which strategies work for you. I think the next line of defense is maybe talking to your coworkers, seeing, just trying to get feedback on what you've been doing. Do they have any input on how you can change the situation or the scenario? The other one is also knowing when to draw the line, right? So I think it's helpful to kind of have a checklist and really think to yourself, did I really do everything that I could possibly do to really benefit from this patient? And there's sometimes where, you've checked all the boxes, but the situation is still not progressing to the patient's benefit. And so if this is the case, you might want to think about referring to another therapist. Sometimes it takes maybe getting a male therapist if you're a female therapist, or vice versa. That might be one strategy. And if all those don't work, I think, bottom line is you might just have to discharge the patient. But I think if you do discharge the patient, I think it's going to be helpful that you try to go through your checklist and try to make sure that you've done everything that you could possibly do. Do your due diligence before signing off.
The next question is, please explain the correlation between years of experience and number of difficult cases. This was reviewed quickly, and I need some more clarification. So in the study, it was done in Turkey, I believe, and they interviewed hundreds of doctors in this teaching hospital. And when they gathered all their data, they found that the doctors with more experience, who were working for longer amounts of time, had less interactions with challenging patients. I think it's just because they knew how to interact with challenging patients. So I think in relevance to OT, what that might mean is that us as newer practitioners might have a more difficult time dealing with challenging situations than those practitioners who are seasoned.
Another question is, what if a translator is not available and the facility will not provide one? I think in this case, thankfully, we at our facility, we are lucky to have translators and even video chats. But I think in this case, if this was the scenario that I was faced with, I'd actually use your Google Translate on your phone. That actually tends to work well in this scenario. So that's one thing. I don't know if Christina has any other.
Sometimes if I'm out of options and the family members there that can help with translating, I can resort to that. But I think it's important to note that if we are providing education, we really should wait until we have some kind of translator service available, just so we can ensure that we're communicating the correct information and that whoever that family isn't skewing what we're saying, just so we can be sure that's what's safe for the patient. Okay, let's see. How is the best way to deal with a patient who refuses to deal with you if you are a different gender than them, especially if you're working on dressing or bathing? So I think something you could try is simulation. Maybe they just don't want to get undressed or work on dressing or bathing. We can just have them pretend, like make sure they have that range of motion to get everywhere. Even if it's just practicing putting on a shirt over a shirt they already have, that might make them more comfortable. But I think that's, where you might have to ask another coworker to help you out, because at the same time, we can't force a patient to work with us. If they refuse, we can do our best to educate, but ultimately it is their decision.
The next question is, do you have any scripting you frequently use to help build a working relationship with a challenging patient? And so I think in this case, what I tend to do is, if you know that this patient is going to be difficult, I think it's going to be helpful to block time, knowing that this patient may take up a lot of your time. I think if you rush things, that's also maybe not going to work in your favor. I do try to make a really good effort to really take the time, especially when on my eval, to try to get to know the patient, really make sure that they feel like they're being heard. And, if they have any qualms, sometimes it's just a matter of the patient is just frustrated and needs someone to listen to. So a lot of times I'll try to take that time at the eval to try to develop a relationship. So it's not necessarily always a script per se, but it's more so just making sure you have time to really help the patient.
I agree with that. I'd also say if you can find something you have in common with the patient, it's a great way for the patient to kind of open up and tell you about themselves, and that can be a really quick and easy way to build some rapport with your patient. The next question is, I'm currently an OT in a skilled nursing facility. How would you approach subacute patients with a lack of motivation? I love this question. It's one of my favorite things about being an OT. For me, it's all about using what the patient wants to do in your favor. So especially in a skilled nursing facility, if they want to eat and they don't have arm strength, great. We're going to use food as a motivation to get them to do those arm exercises and help them get stronger. Same with dressing. If they don't want someone to dress them, we're going to use that goal to motivate them in therapy and hopefully get them to participate.
The next question is, can you provide an example of a difficult patient you had and how you dealt with the situation? This question I do comes up a lot in my caseload, and so I think probably one of the things, again, is which I mentioned earlier, is really trying to talk to your team members. If there's a PT involved, try to talk about the patient beforehand. Game plan is what I said, so that you're saying the same information, you're trying to work on the same goals. Maybe also, I don't think we really mentioned this, but I think it's also helpful for management to know, just to give them a heads up, like, hey, this patient's difficult, because you also want to draw the support of the management. It's really hard to be in this spot if you don't have support from your managers. I will definitely say that, and thankfully, we work in a place where our manager is very supportive and very understanding of that. So I think that's also equally as helpful. Some other things to do is also let the treatment team know. Sometimes it's a matter of letting the doctors, if you work with them, tell them, hey, your patient's not working with me. They're not getting out of bed. They don't want to participate. Do you mind talking to your patient? And a lot of times I do find that most doctors will do that. I mean, assuming that you have that kind of rapport with the doctor, but I do feel like doctors are more than willing to kind of talk to the patients, because we all want the same goal. We want the patient to get better. So that's what I use.
Okay, let's see. And, oh gosh. Next question. On my last clinical rotation, I had a family with multiple members who would always sit in therapy but try to take over the session. How would you approach this? Lynette and I have absolutely experienced this. I think a lot of it is providing education and educating the family why it's important for you to do what you have to do. Sometimes we have to politely ask the family to step out for therapy. That can cause a little bit of tension, though, so I would say if you were to do that, just be very respectful and patient. Do you want to?
And I think it's also helpful to know, when you can use that strategy with a certain family member. I mean, there are some family members where you can't use that strategy. I tried that earlier in my career, and the daughter did not, requested that she get another therapist, and which I understand, but I think, from that experience, I was able to kind of tailor when I could use that strategy and versus when I could not. So that's kind of what we're looking at other questions, sorry.
The next question, when meeting with the family and patient regarding the discharge planning, it becomes apparent in the prior level of function at the initial evaluation was not accurate. The patient and the family are requesting more than what is realistic. What is the best practice when meeting at a family meeting with the patient family to set a discharge date? It's a little different for us at our facility. We don't really have a say in the discharge date. It's kind of whatever the team thinks is appropriate. That's why I think it's also so important to do a thorough job at your evaluation and get an accurate prior level of function, because that kind of sets the tone of your therapy sessions, and it kind of tells us as rehab therapists how we want to progress with the patient.
I think it's also important, a lot of times, sometimes maybe the physical therapist had already done the prior level or obtained the prior level of function, and so sometimes coming in, I know this could be repetitive, but as the OT, yes, sometimes what was written may not be accurate for various reasons. The patient might be confused or delirious, but I think it doesn't hurt to, try to maybe verify and clarify things in your, when you are treating the patient, because that actually might clarify some or prevent things or later on.
Okay, let's see the next question. What is the best way to respond to patients that want to be challenging patients? A patient that regularly states, "I know I must be your challenging patient," and then proceeds to be sexually or socially inappropriate. I think as therapists, we also need, we need to know when to draw the line. We don't want our patients or to put ourselves in that kind of situation that might be inappropriate. It sounds like this patient knows that they're difficult and want to continue to be difficult. I think it's all about how you use your, therapeutic use of self to kind of move away from the sexually or socially inappropriate behaviors and try to do something more.
And I also think, it sounds like the patient wants a reaction from you.
Yeah.
So when that happens, I think it's best to obviously try to respond in a professional manner and not really kind of get caught up in reactions in their what they want you, how they want you to respond. Let's see. And the question is, I am a new grad in acute care OT. It is difficult for me to know when to get as much out of an eval, even when it's not a lot, or when to say a patient refused and write a variance. For example, seeing grooming in supine only versus saying the patient refused and not getting the occupational profile, prior level of function, etc. So I definitely think this will come with time and experience. I know when I first started, yes, that was difficult, but I think as you continue to practice, you'll definitely have an idea of knowing, what you can do in this meantime, and then just knowing what tasks that, you might need to see for the next treatment session. I think those are hard to say, and I think, if you can't obtain an occupational profile for whatever reason, say the patient's intubated or, uncomfortable or not alert, what can you do? You just have to kind of write the reason why. And, I feel like in our facility, no one really, if you can convey that, then no one really, can question that because you tried.
I think another approach is asking the patient what they want to do, what their goals are. I think a lot of the times we go into a therapy session thinking, okay, what does this patient need to do to get home? They need to do A, B, C, D. But really, we also want to make sure we're asking, what do you as the patient want to do? What do you want to work on? So I think if we can do that, we can kind of get a little bit more out of our patients. So that might be another approach you could try. Next question. How do you respond to a family member who, oh, it moved. How do you respond to a family member who wants you to cure a child with CP or MD? That is difficult. I think a lot of it is educating the family member on what our role as occupational therapists are. Remember, we're not diagnosing or giving any kind of medical advice in that sense, but what we can do is educate on what we do as therapists and provide adaptive strategies, especially for a child with CP or MD, so providing adaptive strategies to help them do as much as they can. I know it varies from child to child and the type of CP.
So another question is, I work in a group home setting. Any suggestions on having staff follow professional recommendations when they don't agree? And so a lot of times when this happens, it's trying to explain your reasoning why you are suggesting some kind of maybe positioning, or not positioning, not for group home setting, but
well, I think too a lot of it is educating, again, what we do as therapists. Maybe in group homes, I know at our facility too, the care partners, it's their job to do everything for the patient, to bathe them, to get them dressed, to feed them. But we as occupational therapists want our patients to be independent. So I think it's educating, maybe showing them how you can set up an environment and then having the patient do as much as they can for themselves. I think we have to remember that they might just be trying to do their job. So we want to be respectful, but also provide education. Okay, and one more question. Have you ever had a situation where you felt it was time to have another therapist work with a client, but the family still wanted you to work with? What did you do in this situation? Yes. The answer is yes. I think in this sense, we just have to do our best to work with that patient, just do what's best for the patient. We try to put our own personal biases, to the side and still make the patient our first priority. So in this case, yes, we did continue to work with the patient.
And it was hard because the patient's family member actually said, you work so well with the patient, and so that's kind of hard to disagree on. But I think the bottom line is you always want to keep in mind that, you want that patient to get well, and, I think that's kind of in terms of, in this case, I just had to keep that in the back of my mind, is that, I want the best for this patient. I actually want the patient to get well, and so just kind of working through things.
Yeah, and I think, too, in that situation, we tried to put ourselves in that family member's position, and, if the therapist works well with the patient, you kind of just got to do what's best for the patient in that case. Okay, let's see. We'll do one last question. What do you do with a patient who only wants to do Therax and Thera activities and refuses ADLs? Patient only wants to be bathed, dressed by CNA. How can you measure their ADL levels?
So I think in terms of this case, maybe you want to touch base again with the patient. Say,
well, what if the CNA isn't there? That's kind of how I would spin it. What would you do if, or, kind of try to do what Lynette spoke about earlier, persuading that patient to participate. Well, don't you want to do this for yourself, or don't you want to be able, to take care of yourself? I think, again, if a patient refuses, and we have to respect them, let them do what they want to do. All we can do is try our best and educate.
And I also think it's helpful just to try to link things like, if they live alone, always say, well, you live alone, right? You said, I think it's helpful for you to be able to do as much as you can for yourself, so that's why we need to work on on these things.
I guess we'll do another question. How do we encourage residents who have mental health diagnoses and are difficult to work with? I think that's about finding what motivates them and using what motivates them to your advantage. Again, asking, what do you want to do today? And using that to our benefit as therapists. All right, I think those are all of our questions. Amanda, is there anything else you'd like to add?
No, I just want to thank you guys for presenting today. Thank all of you for attending. And of course, thank you all for being AOTA members. Have a great day, everyone. Thanks, guys.
Thank you. Have a good day.